Hi everyone, I'm going to go ahead and get started. This is Ask the Experts, so I guess that's me. And we're going to talk a little bit today about comorbidities. So this is kind of a broad topic, so really you're going to ask a whole lot of different questions about things. We can talk about mental health types of comorbidities, we can talk about other types of comorbidities, non-epileptic seizures, we can talk about cognitive comorbidities related to surgery, things like that. So that's kind of what I'm here to talk about. I am a neuropsychologist. I'm head of the neuropsych clinic at UCLA, as well as director of the neurobehavioral epilepsy program, which is kind of our program for non-epileptic seizures, things like that, and patients that have mixed disorder. I'm also just a psychologist in general. I do things like therapy and I do things like assessment to try to figure out how people are emotionally functioning and kind of what their needs are. So I guess I'll start off by talking a little bit about general mental health things related to epilepsy and some cognitive issues related to different types of things that can happen in the brain when you have seizures and surgery. And then we'll go into some questions. So I want to start off by first highlighting the kind of real need for good mental health. Not just in general, because I'm a psychologist and I kind of am an advocate for that for everybody, but also just in general, especially for patients who have epilepsy. We have, in patients who have epilepsy, we have a higher rate of things like depression and anxiety than there are in the general population. So in particular for depression, in the general population, about 1 in 5 people has depression, diagnosable depression. A lot of people feel sad at times, but 1 in 5 people actually can be diagnosed with a significant depressive episode. In epilepsy, that ranges from 20 to 55%. So that's almost half of people. In some studies, it's even 60% of patients who have epilepsy have some depression at some point in their life. So it's a huge thing, and it's really important to keep kind of be aware of, not only for the patient themselves, but for family members around them and things like that, and kind of watch out for these things. Another thing that's I want to highlight too is that this is more common in temporal lobe epilepsy, which a lot of adults have. And they think that there might be some kind of like shared mechanism between depression and temporal lobe epilepsy. It kind of affects the same areas of the brain that we see when we look at depression research and we look at where in the brain things are kind of going a little bit wrong. In depression is the same thing as the structures that are going a little bit wrong when you have temporal lobe epilepsy. So it's not unusual that patients have a higher rate of depression. The other thing that can happen in epilepsy is that patients can have a new onset depression following a temporal lobe resection. So that's something where maybe they never had depression before, they have a temporal lobe resection, and then they have new onset depression. Again, those structures that are being resected during temporal lobe resection are the same types of structures that are affected in depression. The amygdala, the hippocampus, temporal lobe, things like that. Same thing goes for anxiety, that there is a high rate of anxiety. Again, those structures like the amygdala, everybody who's heard of the amygdala before, right? Okay, a little almond-shaped structure right in front of the hippocampus. Again, that's another one that's really often related to how the anxiety circuit works in the brain, right? So again, if you're having seizures in that area, those circuitries are just being disrupted, and that can cause a lot of anxiety as well as epileptic seizures. Sometimes anxiety also can mimic epileptic seizures. So you can have things like panic attacks and things like that look like epilepsy. Same thing, you can have epileptic seizures that look like panic attacks. It can be very confusing. So we have a lot of patients that have a lot of physical symptoms, like all of a sudden feeling very anxious or feeling very distressed and having trouble breathing, things like that. That can be an epileptic seizure. It can also be a panic attack. It's very hard to kind of distinguish the two. Another thing I want to just highlight is that patients who have epilepsy also have a higher rate of suicidal ideation than in the general population. This is really important to talk about. It's often something we don't want to talk about, but it's really important, and they have a higher rate of suicide than other patients in other medical populations as well as in the general community. So again, it's something to really be aware of because we want to do everything we can to prevent suicide and things like that, as well as just improving everyone's general well-being and mental health. We do know that for patients who have epileptic seizures as well as patients who have non-epileptic seizures, both types, the more mentally well you are, the more well-controlled seizures can be, right? So having a lot of depression, anxiety, worry, things like that, that generally doesn't help the situation, right? It doesn't necessarily mean that if you don't have anxiety, you don't have seizures. It just means that it only serves to make them worse oftentimes. Things like stress can be a trigger for seizures, things like that. So we want to do everything we can to keep things as kind of calm and copacetic as possible. So, okay. I just could go into a little bit of the cognitive kind of things that might happen related to epilepsy and epilepsy surgery. Really, it depends on whether or not you have generalized seizures, for instance, or you have more focal seizures. If you have more focal seizures, particular areas of the brain can be affected, and that might affect how your thinking is. So this can be things like your temporal lobe, for instance, does a lot for memory, does a lot for language. So people who have temporal lobe epilepsy often have things like memory difficulty. They have things like trouble finding words, so that kind of, you're talking and you're like, oh, it's, I know that thing, right? More than usual. Everybody has that problem. More than usual. Other parts of the brain, like the frontal lobe, can cause a lot of difficulties with things like attention, concentration, what we call kind of inhibition, so the ability to not say something when you don't want to, that kind of like filter function where you might not mean to say something to somebody, it might be a little rude, something like that, but the brain, the frontal lobe of your brain does the job of stopping you from saying those kinds of things. So that's kind of what that part of the brain does. So the occipital lobe in the back, primary, it's only vision, that's what it does, it's got one job. So if you have difficulties with seizures in the back part of your brain, in the occipital lobe where you have a resection there, oftentimes you can have difficulty with parts of your vision being affected. So that's kind of what I'll talk about. I can answer questions or I can just keep talking. It's up to you guys. Anybody have a particular question they want to ask? Or anything that's going on for them? Yeah.
I was just curious what your opinions on cell phones causing seizures.
Cell phones causing seizures. I don't think there's a lot of good research evidence at this point to kind of definitively support that at this point. There's also the question of whether or not they cause brain tumors. That often comes up when I talk at the brain tumor conference as well. There are radio frequencies that come out of cell phones. I don't think we know enough about those types of radio frequencies and how they affect the brain. Because you get a lot of radio frequency from a lot of things, microwaves. If you just drive in your car, that's radio frequency as well, just going outside, things like that. So how that affects it specifically is kind of unknown at this point. Question?
I was just curious because I didn't start developing epilepsy until it was always on cell phones or screens.
Yeah, no, there can be seizures that are caused by photic stimulation, so kind of screens and flashing lights and things like that. So that's another thing that we do know can cause seizures as well. Other questions or things? Yeah?
Could you talk a little bit about migraine and epilepsy?
Yeah, so I'm not a neurologist myself, so I can't speak necessarily to the systems of migraine and things like that. We'd have to talk to a neurologist about that. But I do know that things like stress, anxiety, things like that make migraine significantly worse in all people, not just people who have epilepsy. So I know that's not the answer to your question you were asking, but again, I'm not a neurologist. I know it says migraine on my little thing, but I think they got that all.
I was wondering, like, when we were looking for therapists, we went through a few therapists, hoping to find somebody to deal with anxiety. Mm-hmm. And it seemed like I could never find a therapist that really, they always go into like communicating better, and it always brought out all these feelings that make everything worse. And I'm just wondering, well, is there any way that at some point, you know, as you as doctors could start finding that, like, a program for people with epilepsy where you could be directed towards somebody that actually deals with those issues? Because I just couldn't find it, and it's always been a struggle.
Totally understandable, yeah. I mean, the one thing I will say, it's hard to find a therapist. Who's had trouble finding a therapist? Okay, that's like 100% of everybody I've ever asked. So, some people nail it on the first time, right? And it's like, wow, this is such a great fit. I think the one thing to remember is that therapists are people too, right? I'm a person, and I have a personality, and not everybody gets along with my personality. It's quite lovely, I know, but not everybody does. But I might not be the right style for you, for instance, right? And I always tell people it's just like getting your hair cut, that like if you got a bad haircut, it's not that you would be like, well, I'll just stop getting my hair cut forever. Go to find a new barber, right? Go to find a new hairdresser, right? Same thing with a therapist. If it doesn't work out, it definitely, I like to hear that you kind of keep searching around for somebody. The other thing I'd kind of point out is that any type of therapy, so for instance, cognitive behavioral therapy, dialectical behavior therapy, there's all different types of therapy. The one thing that we do know is that all types of therapy initially make you feel a little bit more anxious. That's a drawback to therapy, right? The reason why is because you've spent all this time your whole life avoiding thinking about things that make you anxious. And when I start doing therapy with you, now I start talking about the things that make you anxious that you've been like, no, we'll just forget that, right? On a daily basis, right? And so the problem is, and I actually warn people when I first start seeing them for therapy, I'm like, we're going to talk about anxiety, and it's actually going to make you feel worse in the first few weeks, okay? And that's normal, and it's normal because I'm now stirring up all the stuff that you have tried so hard to keep down on the floor, right? The nice part is, though, is that if we get that stuff stirred up, especially things related to anxiety and avoidance and things like that, that actually is what helps push forward, like, progress, right? So I want you to be, if you're not anxious when you're seeing me, then I'm actually not doing my job quite right. And now I don't want to get you too anxious. So there's like a nice therapeutic level of like me working with you on something that's going on and me making you so anxious that you're in a panic, a full panic or something like that. That's not okay. That's not appropriate or anything like that. But you will feel more kind of disturbed than usual when you first do therapy. And again, that's because we're bringing everything up that used to be down low. So. What I would do is I would give it a number of weeks, right? Usually by like week 4, week 5, that's when you start to kind of feel a little bit better in therapy, but it will take a little while. That's the unfortunate part. It's not like a magic wand, and it's not like a medication that I can just give you and it just all of a sudden you don't feel anxious.
Yeah, I was just always wanted like maybe beforehand they can teach some kind of tools to help you deal with the anxiety before they bring out the anxiety.
Yeah, so the first part, so when we do cognitive behavioral therapy, the first thing I'm going to do is talk to you about what makes you feel anxious, right? Because what I really want to understand is what kind of is going on there. So just even in talking about it stirs up a lot of feelings for some people because, again, they try to avoid thinking about it. But then I'm going to go into teaching you tools about how to go about dealing with anxiety. And the last part is we'll confront the anxiety with those tools, basically. That's kind of the steps to it. Yeah.
How do you approach somebody who has had epilepsy surgery? How do you find that?
Do you mean in therapy or in
I guess,
assessment of cognition?
or maybe what's the overall plan usually?
Okay. You mean for therapy or like treating mental health or treating kind of cognitive stuff? A little bit different, yeah.
Yeah, I guess I don't know
That's okay.
exactly what I'm talking about.
That's okay, yeah. So with somebody who's had epilepsy surgery, generally that's a focal thing. So we do a focal resection, unless you've had VNS surgery, which is a little bit different. But if you're talking about
I
like
guess, focal resection.
a focal resection, okay.
Yeah.
So what we'd want to do is a full kind of neuropsych eval on that person, just to see kind of where they're at, right? Hopefully they've had one before surgery, but at least after surgery we can start doing that. then we can kind of figure out, and first of all, I always recommend that people have this done like 6 to 12 months after surgery. I know that seems like a really long time after surgery, but really we want your brain to heal a little bit, right? If you think about it, we wouldn't have you run a mile a week after a knee surgery, right? It's the same thing for your brain. Neuropsych testing is it's taxing on your brain. So we want to give you a little chance to recover. We know your brain is going to go through a lot of changes and do a lot of recovery during those first 6 months. So we'll kind of figure that out after. Then afterwards, we want to figure out, okay, where are you at now? And what kind of rehab might you need? So kind of cognitive rehabs might you need? And what kind of accommodations might we help you with and how your brain functions, right? So for instance, if we take out the dominant hippocampus, so the hippocampus has everybody heard of the hippocampus before? Okay. Who knows what the hippocampus does? Anybody? It does some emotion stuff. It does memory, right? And a lot of that's tied to emotion as well. Memory is its primary function. That's really what the hippocampus does, right? It gets the new stuff in, circulates it around, stores it for later, right? Once the memories are stored, they're actually stored in a different part of your brain. They're not stored in the hippocampus, all right? So if we take out the hippocampus, you don't lose anything you've already learned. It's the problem is learning new stuff. So conversations you've had with people and things you've seen and things you've done, things that happened last Tuesday, that's what the hippocampus's job is for. It's not for your childhood, it's not for anybody in your family's name or anything like that. That stuff's already stored elsewhere, right? So the hippocampus, can cause some memory difficulty. So I see some nodding. So if we take out the hippocampus that's responsible for your verbal memory, right? So your ability to remember things you've heard, that can cause a lot of difficulty in people, right? Because we are a very verbal species. We like to talk to each other, and that's how we learn about things, right? Very rarely do you ever just see a bunch of pictures and just have to remember them, right? But the problem is your brain is never really going to make another verbal hippocampus again. That's it, right? That's why we do testing beforehand, because we want to know kind of what the cognitive risk is to surgery, right? But after it's gone, it's kind of gone. That means that if we test you in a kind of structured office environment, and I say, I'm going to give you a shopping list, and I want you to remember all the lists, all the 15 items on that list, right? That's really difficult, right?
And
if
that's why I keep the list.
Right, if you've had that hippocampus removed, right? So what we would tell people, though, is, okay, how do we accommodate for that once that's gone, right? So there's several ways to do this. One is keep a list, write it down, right? No longer rely on something you can hear to remember it, right? The other thing is to try to remember things visually. So if you are needing to go to the store, get groceries, try to remember where in the store things are and kind of make a little trail for yourself. And then that actually will help you remember because it's a visual memory, which uses the other side than the verbal memory does, right? So that's kind of like an accommodation strategy rather than a kind of rehab strategy. There's two kinds of thoughts about it. So those are the kind of things that a neuropsych assessment can assess. So the other thing we do in a neuropsych assessment is assess your kind of emotional functioning. So how are you functioning emotionally? How are you doing with levels of depression, anxiety, worry, panic, things like that? What's coming up for you? What kind of stressors are you having in your environment, in your everyday life? And then we can recommend different types of various therapies, things like that, ways to work with your family on how to kind of reduce stress in your life, those kinds of things. So.
Yeah, isn't the hippocampus also like a processor for the amygdala, so it affects the emotions?
Say that again?
Isn't the hippocampus also a processor for the amygdala, so that's why it can affect emotion, like if you have an aura of being terrified or whatever,
Yeah.
sometimes you have damage in your hippocampus.
That's right. So the amygdala and hippocampus work in concert together, right? So I'm a big visual person, so there's your brain, right? Looking from the side. So the amygdala, this is inside of the temporal lobe. There's an amygdala structure right here, and behind it is this hippocampus, which is this long, squiggly thing. Looks like a seahorse. It's actually the Greek word for seahorse. That's why it's called hippocampus. The amygdala is this little structure at the front here. And what it does is it's primarily responsible for the fear circuitry in your brain, right? So a lot of people who have left temporal lobe seizures have like an aura of fear. They can have a lot of panic or fear, especially if they have this front part of their temporal lobe affected. But these two work together, right? the one thing that your amygdala helps you to do is really, really remember things you were really scared of. Right? So anybody can think of things they're really scared of, and it's like a flashbulb memory of like, oh my gosh, there it is, right? But if you ask you what you ate for breakfast last Tuesday, you're like, no, it wasn't that important, right? So the amygdala is really tied to that, right? And so emotion helps us, and it remembers happy things too. Things that are very, very happy were also, kind of when you got married or your child was born or whatever, it's kind of that memory that's stuck in there forever, right? Same kind of thing. So, yeah.
Going along with the fear side, I actually have 3 different types of auras, and fear is one of them, but that's the less often one. More often I have like a rolling sensation from my body. So does that mean that I have different areas where the seizures originate from?
I mean, obviously they would want to do that via EEG to figure
Okay,
that
just
out.
curious,
But that
when you mentioned that
they
fear,
can
yeah.
both be a temporal lobe. Another sensation people get is like a falling
Okay,
or a roller
right.
coaster sensation with temporal lobe epilepsy.
Okay.
So that's another one that it still involves the hippocampus.
Okay, so I was curious, so.
Yeah, exactly. Yeah.
So I just had a question about the non-epileptic seizures and epileptic seizures. So my daughter has both.
Okay.
Do you have any recommendations on, because the non-epileptic seizures mimic a regular epileptic.
Yes.
So as a parent, it's really hard for me to know which are which. And
Yeah.
she is seeing a therapist and we're working on the
Good.
cognitive behavioral.
Good.
Right, so we're trying to get them down in numbers. But, do you have any recommendations for me to be able to maybe distinguish when she's having maybe a non-epileptic?
Sure. I think the best thing that's been helpful for family members at UCLA where I work is to have video EEG done where you capture both types. And you can actually, and have the neurologist go through it with you and say, okay, this one is epileptic and this, and sometimes they look identical. Sometimes there's subtle differences between them where you're like, oh, they got that hiccup beforehand or whatever it is that sets it off, and that's the non-epileptic versus this is the epileptic. Because it is very difficult. That's one of the hardest things about having a mixed seizure disorder is that, and particularly for the patients too, because they don't know, is the thing I'm feeling right now an epileptic seizure or an epileptic seizure? It's kind
And
of,
then besides doing the neurologist thing, working with a therapist and working on the cognitive behavioral, that's pretty much just what you would do.
yeah, and what I would do is kind of usually we do an assessment to recognize kind of what are the underlying things that are kind of causing. Is the person particularly, like, are they a worrier, for instance? Are they more, prone to panic, or do they have any trauma, for instance, or other kinds of things that would affect, or ways in which they go about approaching the world and things like that that would affect how they respond to their own body cues, essentially. Yeah.
I'm just curious as far as the anxiety and depression. My husband has seen a number of therapists, unfortunately not with good experience, so he stopped.
I apologize for all therapists.
He was one of the ones that was diagnosed in his 40s. Never had a problem at all since seizures. So he started going to therapy at that point based on the doctor recommendations. And it was either it's your medication, it's a side effect, you just have to accept it and deal with it.
Yeah.
Or the other side is, well, you're probably having seizures because you've had depression and anxiety your whole life. There's no way of knowing, and of course, depending on what they think it is, their treatment is different. Is there a fine line somewhere in the middle?
Yeah, I appreciate your frustration. Yeah, I mean, I think the one thing is that depression and anxiety, panic attacks, things like that, none of that can cause an epilepsy if you don't have epilepsy, okay? If you have epilepsy, those things, if you have a lot of stress or anxiety, that can result in an epileptic seizure, but none of it, if you've never had epilepsy before, that can't cause it. So even somebody who's having an extreme panic attack in front of me, I know if they do not have epilepsy, it's not going to cause epilepsy, right? I think one of the key things is finding a therapist who is comfortable with epilepsy, which is a very hard thing to do, as well as finding a therapist who's comfortable with non-epileptic seizures as well. Because same with a psychiatrist too. You really want somebody who is not gonna just say, oh, that's a seizure, I probably shouldn't touch it, or oh, that's a medication thing, or you have a psychiatrist that won't prescribe something that's needed because they're like, I don't want to mess with the AEDs, right? We have a bunch of psychiatrists that I know around that I won't name that won't give an antidepressant to somebody. because they're like, well, I don't know anything about the AEDs, I don't want to touch it, right? Well, that's really inappropriate because the person would be significantly benefited from an SSRI or something like that. And it absolutely can be prescribed at the same time as AEDs. So, you know, I think that's really the key, is finding somebody who's comfortable with epilepsy.
Yeah. And then going along with what you're saying there, it's sort of like another fine line, for like a better phrase, because you have AEDs that are antidepressants.
That's right.
And then you have AEDs that can cause depression.
Right.
As a side effect. So
And
you're
so
like,
if you have a good psychiatrist who really knows what they're doing and is comfortable working with that in concert. So you have other things like Depakote, Lamictal, things like that are for mood and anxiety and things like that. So they can work in concert with those to kind of fine tune what's going on. That's really the key thing. Yeah. Is that question okay?
I was just curious why so many doctors or neurologists I speak to, their answer is always a pharmaceutical.
Are you talking to MD?
Well, I'm talking to anyone.
Usually you're talking to MD, that their first answer is pharmaceutical. Yeah.
But it just seems like that's always the solution.
I know.
But and anytime I bring up something like lowering stress, CBD or
Yeah.
THC or anything of that nature, it's always, I'm the doctor.
Yeah. I mean, I think that's, you know,
I just don't get why something that causes so much side effects
right.
is always being promoted versus something that.
Yeah, I mean, I think that's, any good physician should recognize that tolerability of side effects is a huge factor for patients, right? If the side effects that you have from your medications are so bad, A, patients don't take them, right? And that's risky. And then B, it affects quality of life. And if you have a really good physician, they will weigh that and say, you know what, that's it, we're stopping the X drug because that's not, it's bringing down quality of life so much, right? That's not okay, right? There are certain medications that I won't name in this room. I don't have any pharma affiliations, by the way. But there are certain medications, for instance, that affect mood. There are certain medications that affect cognition pretty heavily. So much to the effect that as a neuropsychologist, I will not test you if you're on those medications. I make the neurologist take you off so that we can actually see what your brain is doing. Because I know they're just going to wipe memory, they're going to wipe attention, things like that. So, you know, I mean, I think most.
I mean, it almost seems like there's an agenda to promote this drug versus bringing up any other type of.
Yeah, I mean, that's unfortunate, you know, you shouldn't have somebody that's especially promoting a particular medication or something. That doesn't seem like good medicine to me. But, you know, a lot of MDs, especially if you go see a psychiatrist, they're going to give you a prescription for a medication.
They'll give you a prescription if you show up.
Right, exactly. I'm a PhD, right? So I don't do that, right? And I can't prescribe medications, but I also work with a lot of MDs though who do feel like we should try a lot of things that are not drug related, right? And you know, I think the research is still kind of out on whether or not THC, CBD, things like that, what effect they have and for who, things like that. I think that's been the biggest challenge for us as researchers and docs, is that we can't research it. We can't get any funding to research these things because the government won't fund research on marijuana. So go to your congressman because I think it would be really helpful because then we could at least know what's going on. You know, the one thing that we do know is that THC definitely affects memory, definitely affects attention, definitely affects working memory, processing speed. It also definitely increases anxiety, ironically, right? The way that it works is that it actually increases the response in the amygdala. So when they do functional MRI studies in research subjects on this, they can see an increase in response in the amygdala, whereas if you have CBD, you have the opposite effect. Okay, so when you smoke marijuana, you have both of them in there. They kind of balance each other a little bit. However, if you really wanted to help your anxiety, the more evidence is for CBD, than THC. Even though THC gives you that nice mellow feel, it actually is serving to increase your anxiety in the long run because, again, it's increasing these kind of receptors into the cannabinoid receptors in both the amygdala and the hippocampus, thereby kind of jacking up your anxiety, right? So that's just one thing we do know. So if you were going for an anxiety, CBD is a known anxiolytic, means it reduces anxiety. So just I think behind you.
Yeah, so some young adults, epilepsy itself and having seizures makes them feel set apart, makes them feel other. And so they don't want to do something else like therapy that makes them feel even more set apart.
Totally.
What kind of things would you recommend for families to either deal with their cultural stigma of therapy or the kids not wanting to feel set apart?
Yeah.
What kind of resources would you recommend for that?
I mean, it really depends on where you live. If you live in LA, everybody has a therapist, right? I don't know a single kid that doesn't have a therapist. They're like, oh yeah, this therapist this way, this therapist. So there's not as much stigma. I would say the benefit of that is that there actually is less stigma around therapy and going to therapy and mental health in general. I think the younger generation actually has a better pulse on that and is reducing stigma just on their own, and I think it's a wonderful thing. But yeah, you're right. And the one thing that's really hard for particularly adolescents and young adults is they often, feel very embarrassed about having a seizure in front of people. They just want to get through their day, and adults as well. This is not just for them, but in particular, when you're a teenager, you care about everybody and what everybody thinks, right? And, one quality of life deterrent for a lot of teenagers is having seizures at school, right? They really have a hard time. That's such a difficult thing, especially ones that involve a lot of motor, or things where they kind of lose awareness and then do something silly in front of their friends and people laugh and things like that. And people have done very cruel things like videotape somebody during a seizure and then like have everybody laugh about it and things like that. So it's not that they're just making this up in their head. I always recommend that people get involved with other people who have epilepsy, so that at least one other person that also is going through the same kind of thing, That's true for everything, right? If you just have that one buddy, that one single person that truly understands you in life, like that's, it's great to have a million friends, but you really want that one person that really gets you, So I always recommend, as well as therapy, I do recommend other things that, like meetup groups and, the Epilepsy Foundation groups, support groups, things like that. Big events like this where you can go and meet up with other people, and I think that's helpful, honestly, because it just makes you not feel so alone, Yeah.
Can you say anything about the correlation of autism and epilepsy?
Yeah, I mean, there is a pretty significant correlation at this point that they've discovered. They don't know necessarily, it's kind of a chicken and the egg question a little bit, right? So we have patients who have autism, who have epilepsy as well. We have patients who have epilepsy that have autistic features, right? So they have symptoms of autism. Again, autism is a behavioral disorder, right? So all we're doing is counting a bunch of things that you do and saying that kind of fits into one bag, right? So I think, and the other thing is that with every psychiatric illness, there are multiple etiologies. So there's many ways you can have the label of autism, right? You can have epilepsy, you can have microdeletions on your DNA, you can have various things, you can have idiopathic, meaning we don't really know why it is, right? Same thing for ADHD, right? You can have ADHD straight out of the gate as a little 5-year-old running around, being kind of like, whoo, You can also have ADHD-like symptoms if you have a frontal lobe tumor, right? Also affecting the same thing, and behaviorally, that's what it would be as well, So, and the treatment would be the same, So it's part of it is like what the label is, and part of it is like, well, you have the symptoms, here's the treatment, and it's pretty much the same, So we do have a lot of patients though who have autism and epilepsy, right? In particular, and this is kind of anecdotally, I've noticed that a lot of patients who have right hemisphere seizures have more autistic features than patients who have left hemisphere seizures, right? Why this is, we don't know. There's a lot of research that looks at the right hemisphere of the brain and what it does, right? So if the left hemisphere is responsible for language, it's not that the right hemisphere is silent when you're talking. The right hemisphere is doing things like picking up on prosody, right? Which is the kind of sing-songy part of my voice, right? When I ask a question, my voice goes up, right? And when I'm done with the sentence, it kind of goes down a little bit. That's what prosody is, right? So you can tell how I'm speaking and you can sense my intonation from that. That's what the right hemisphere does. And people who have seizures in the right hemisphere sometimes have dysfunction of that. They can't kind of tell those things, which again, looks like what happens in autism, right? So people who have autism have trouble reading social cues. They have trouble reading social language, your intention of things, what you really mean by that kind of subtlety of language. If you're not talking concretely, you're talking more in the abstract, things like that. So, yeah, so it's kind of, it's a mixed bag of both and a little chicken and the egg is what I would kind of say. So, yeah.
Along those same lines, we have a 17-year-old who is on the spectrum that has auditory processing issues and is full functioning and he does have epilepsy. And we're getting ready to kind of send him into the world.
Yeah.
And he does have a really amazing therapist he's been seeing for many years
That's
now.
great.
And we'll continue to see him as he goes
Good,
on.
good.
But do you have any words of advice or how do we help him manage? Because he is a very literal person.
Yeah.
And he doesn't have inflection. And,
Yeah.
you know, he has to have a routine and it has to be very specific and,
Yeah.
you know, all the things that go with that. So how do we help him manage his world when we're not there to manage it?
I know. Well, and that's a scary thing for all parents.
I mean,
but it's particularly
just so, like, I can't even believe we're here.
Right. And so I think, you know, the one thing that you can do is have him get support, continue to get support. Like you said, you have a therapist that's working with him. But social skills classes, for instance, oftentimes you think of them just for little kids, right? But actually, you know, at UCLA, for instance, and I know they have this at other places too, we have programs where we have teenage programs, we have young adult programs, and the young adult program for patients who are on the spectrum have things like how to get a job, right? How to go and do a job interview and interact appropriately with the interviewee. How to go on a date, right? How do you flirt with somebody, right? When you have autism, you might just look at them and keep looking at them from across the bar. And if I look at you a little too long, it gets a little weird, right? But, so what they do is they actually concretely teach them, you look away, then you look back. Then you look away, then you might look back again. And that's actually, you know, you think it's because if you don't have autism, that's a natural thing that you just get. But if you do, that's a very hard thing and you don't just get it. It's the fluidity of social interaction is very difficult. So I'd highly recommend those kinds of things just to provide that support for him as he's going through those things.
I'm just curious, do neuropsychologists or psychiatrists do anything for pediatrics besides like assessment? Do they provide therapies? Because like my daughter went to see one to help get her a diagnosis so she can see an ABA therapist. Now I'm just curious, like when people see a therapist, we're talking about for mental health or like.
Yes, so the therapist is a loose term. So neuropsychologists like me, we're very focused on assessment. Right? So most patients I see, I do an assessment on, and then I send you on the way with recommendations like see all these people. Therapist is a very kind of broad term. So as a psychologist, I'm a therapist, right? So I've been trained in doing various modalities of therapy for various types of patient populations. I see both adults and children. But then you can have other people like MFPs, so American Family Therapists, social workers, things like that, who also can provide therapy. They maybe have different levels of expertise and things like that, but they certainly can do a good job doing various types of therapy. You just have to kind of get the qualifications. There's also like ABA therapists, for instance. They're a different section of therapy as well that provides in-home kind of care and kind of like in-the-moment behavioral like remediation for kids.
I guess I'm also asking because she's showing like she has interest in stuff before, and now like this past summer she stopped showing it. So I don't know if there's like a depression.
Yeah, that's a really good question.
I don't know,
Yeah.
and she has a hard time expressing. So I mean, how do you work with that if she particular
Right.
therapist.
So, right, if you have somebody who has difficulties with language, for instance, or had difficulties with intellectual function, for instance, maybe they're kind of lower on the intellectual spectrum, you really need a therapist who's well-versed in treating individuals who have those kinds of things, right, and those kind of needs. Because
Yeah.
the therapy, the way I would provide therapy is a little bit different, right? So if somebody who has a little bit of intellectual difficulty, I might be more concrete in the way that I'm providing examples of things and doing less of like, or if I have somebody who's on the spectrum, I would be doing less like, what do you think that person is thinking, right? That's inherently a problem in autism, right? So you don't want to do that. You want to kind of work with other ways, and having somebody who knows about those things is really helpful.
Is there a type of credential or, a specialist who can deal with that sort of issue?
Yeah, I mean, I think
kids?
you want to find somebody who does have that experience in specialization. So I'm a psychologist, but not every psychologist has experience in that. We're certainly the people that went to the longest school, for what it's worth. I don't know if that makes it any better, but maybe that we're just not as smart if we went to school for so long. But we have a longer period of training being a psychologist. I had 6 years of graduate school, I did an internship, I did 2 years of fellowship, 3 years of fellowship, and then I finally got to be my own person. So yeah, I had a lot of training and a lot of experience and a lot of people helping me to figure out kind of how to do things. Whereas some other programs are only like a master's level therapist is a 2-year program, and then that's it.
Because I think I have seen like pediatric psychologists, but I guess that would be kind of like the first group people to look at.
I would, yeah. Especially somebody that maybe works in a clinic that has patients who have developmental disabilities like autism or something like that.
Comment first. One is, if you mentioned earlier about if your therapist isn't working, find another one, and I figured the same goes for the doctors. So for the people who were mentioning back there, I've changed doctors in the past when things didn't work, so you have the right to...
100%.
Yeah. So
your medical care and your mental health care is your right. And you absolutely should be an advocate for yourself.
Yeah, so the biggest thing is advocate, like you said. So going along with the memory, I remember one medication, and for life of me not remembering the name of it, but that one, my memory was so bad that all I could do was say, what's that thing that you sit on with 4 legs, but I couldn't think of the word chair.
Yeah.
Okay, my memory was that bad. Now that I've gotten older, I can, that's fine, I'm not having those kind of issues, but there are times where I'm finding I have more issues with like my short or even long-term memory. And is that just simply an age thing, or could that be because of years of AEDs?
Or seizures.
Or seizures.
That's the other thing.
Yeah, or do the seizures affect the brain over time and,
So the seizures can cause damage in the brain. The more often they happen, the longer they go, the more neuronal damage can happen.
Okay.
So kinds of memory difficulties, you don't look that old, so I'm going to guess that you're... Well, I'm guessing you're probably not at the age where I'd be like, oh, we're thinking about dementia, right? So if you notice a decline, it could be from things like the epilepsy itself, the AEDs as well, though what a neuropsychologist like me would do would track a timeline to see if it actually kind of went along with like changes in medication or if it actually has been more gradual than that over time despite changes in medication, which might be more indicative of the seizures themselves.
The one with the chair, that was 25 years ago, and after that things got much better.
Okay.
I'm talking about like in the last 5 years, so
Yeah, exactly. And as we age, our brain ages too. So the things that we could do more easily before, especially if you have things like epilepsy or a brain injury or something like that, they actually become harder faster than they do for other people who don't have that. So.
Okay.
Someone was mentioning how sometimes, a lot of times, meds don't work for certain people, and how an MD wasn't really suggesting other things. Shouldn't you aim for like a neurologist who specializes in epilepsy, like an epileptologist? Is that how you say it?
Yeah.
Who might be more open to be trying other things like neurosurgery or implantations or changing your meds, and plus also, as we all probably know, like medications can have horrible side effects. 100%. So they might be more likely to know, okay, we need to change you to another one or try a different combination.
Absolutely.
Or find out these suckers don't bring it all.
Absolutely. You should always.
And they might be more open if somebody has depression to look into some sort of treatment.
Right. Yeah. I would always recommend getting a second opinion if things don't feel right. There are bad doctors. There are bad therapists. I'm not gonna lie. Not everybody's a winner, right? There are doctors who have terrible bedside manner that just see you, talk to you for 5 minutes, look at their chart, and then give you a script. I've been to those doctors. They're not great, right? And they occur in every specialty. But finding a good one is really key. And the good ones really consider all the things, and they consider you as a whole as well, not just this part of you, which is just the epilepsy, but you as a whole. And I think that's one of the problems, if I don't mind soapboxing a little bit, with academic medicine or medicine in large medical centers anyway, is that everybody has their little specializations and they don't kind of talk to each other or even think outside of their own little box. You kind of need people to do that, because you are a whole person. That's everything. All right, let me just check on the
I have a question.
Yeah, go ahead. Yeah.
So I developed seizures later when I turned 20, but since then I've noticed huge differences in long-term memory, short-term memory, really just the ability to learn new things and just the general fogginess.
Yeah.
Is there tools or things you can be doing to help pick some of that back up?
Sure.
Or is that just kind of well,
just gone forever? Yeah. You're 20, it's gone forever. No, I think this is a really important question. I think it's really important to figure out where that stems from. Does it stem from the medication itself? Because there are certain medications that, we don't call it Dopamax for a reason, right? Okay, that's one of the ones I won't let people be on, right? Because when they give it to people who are healthy, they test their memory, it reduces memory by 50%, right? So they had a college student sample that they test their memory, they gave them Topamax, they tested again, reduced by 50%. These are healthy people who do not have epilepsy, okay? So first things to first is to figure out exactly where that's coming from, because a switch in medication might relieve all of the symptoms, right? And it's not worth it to go through lots of cognitive rehab strategies if it's just a change in medication to fix it. The other question is are the seizures playing a role, right? So it's not just late in life that can happen, it can be at a younger age too. The longer your seizures last, so if you have episodes of status, for instance, your seizures are lasting longer than 5 minutes, things like that can be a problem for cognition. If you have many seizures, that can be a problem. If you have a lot of generalized tonic-clonic seizures or grand mal seizures, that can be a problem for cognition. So all those things would be kind of good to figure out. And then what I would do is I would get neuropsych testing, because then they can figure out, as a neuropsychologist, I can see your profile and I can say, oh, let's do rehab strategies here, not here. Don't do these ones, do these ones, because this is really what's suffering kind of thing. So.
By the way, pyramid was the one with the chair. Or I couldn't think of the chair. It was the pyramid. When you said it, I'm like.
All right, I actually have to go, but I'm happy to answer some questions in the back if you guys they're timing me out here. So, all right. Thank you guys.